Bismillahirrahmanirrahim. The today's topic for discussion is dermatitis. The learning objectives of this lecture are that by the end of this lecture, the students will know the different types of dermatitis, the clinical features of common types of dermatitis, and the management of different types of dermatitis. Terms dermatitis and eczema are currently used interchangeably. The term eczema truly denotes an acute weeping dermatosis. All forms of dermatitis may present with edema, with erythema, and oozing of fluid from the lesion. There is another popular term which is used is known as lichenification. Lichenification is in fact the thickening of the skin, and it has a very shiny surface. It results from chronic rubbing or scratching. So chronic rubbing or scratching leads to thickening of the skin, which has a very shiny appearance, and that is known as lichenification. And this develops in the later stages of dermatitis or eczema. Now, there are different types of dermatitis. They are atopic dermatitis, nummular eczema, contact dermatitis, allergic eczematous contact dermatitis, seborrheic dermatitis, then dry skin dermatitis, that is also known as osteototic eczema, then dandruff, then keratosis pilaris, Petraeus alba. So these are the different categories of dermatitis. The atopic dermatitis, the contact dermatitis, seborrheic dermatitis, and Petraeus alba, they are commonly seen in pediatric population, and we will discuss these four conditions one by one. Now, the most important and the common condition is the atopic dermatitis, which is also known as eczema. This is the most common chronic skin disease seen in infancy and childhood. It affects 10 to 30% of children worldwide and frequently occurs in families with other atopic diseases. Infants with atopic dermatitis are more prone to develop other allergic disorders like allergic rhinitis, like asthma, in the later part of childhood or adolescence, and this is properly popularly known as atopic march. That is, the one allergic condition progresses to the other allergic condition like rhinitis and asthma. Atopic dermatitis may be acute, subacute, or chronic inflammation of the dermis and the epidermis. Most of the children, they develop atopic dermatitis before the age of 1 year. Almost 60% of the children develop this condition before the age of 1 year, and 90% of the patients present with this condition before the 5 years of age. The remaining 10% of the children, they present between the age of 5 years and 30 years. The pathogenesis of atopic dermatitis Atopic dermatitis is a polygenic disease. In other words, it is a multifactorial disorder. These children are genetically predisposed to develop atopic dermatitis, and various environmental factors, they act as triggers and precipitate the illness. The primary defect in atopic dermatitis is an abnormality in the skin barrier formation due to the abnormality in a filaggrin gene. This filaggrin is a structural protein required for the integrity of the epidermis and dermis. As you all know that epidermis and dermis are the important barriers against the invasion of the skin by the microorganisms. So when there is disruption of this barrier, the organisms, they gain entry into the body and cause infections. So when the filaggrin gene is defective, the structural protein filaggrin is not synthesized properly and it is structurally abnormal and will lead to disruption of the barrier function of the epidermis. Both IgE mediated and cell mediated hypersensitivity reactions are involved. Now, there are different phases of atopic dermatitis. Phase 1 or acute phase, lesions are extremely pruritic with erythematous papules. Generally, the lesions are localized to the face, scalp, and extensor surfaces. Subacute phase or phase 2 is characterized by erythematous, excoriated, and scaly papules, and they may affect the flexural surfaces like popliteal fossa, like cubital fossa. Chronic phase or phase 3 is characterized by thickening of the skin or lichenification. So in the chronic phase or phase 3, the involved area is thickened, it appears shiny, and this is known as lichenification of the skin. The diagnostic criteria of atopic dermatitis includes major criteria and minor or associated features. One major and 3 or more minor features, if present, then the patient can be labeled as having atopic dermatitis. The major criteria are pruritus, typical and age-specific changes. should be present. For example, there may be extensive itching, scratching and excoriation in the phase 1, and in the phase 2 there may be weeping lesions, there may be scale formation, and in the chronic stages there must be lichenification of the area. And then family history is also one of the major diagnostic criteria of atopic dermatitis. The minor criteria or the associated features are that the onset of the condition must be before the age of 2 years. There must be history of atopy in the family, like history of asthma, like history of allergic rhinitis. Xerosis, severely dry skin is a hallmark of atopic dermatitis. Ocular or periorbital changes, then perioral or periauricular lesions, elevated serum IgE level, positive results of immediate type allergy tests, cutaneous bacterial, fungal or viral infections, facial erythema, non-specific dermatitis of hands and feet. So as I have already told that the presence of one major, 3 or more than 3 minor features is diagnostic of atopic dermatitis. Now if you look at this picture, this child has atopic dermatitis. You can see that this child has erythematous papillary lesions, and due to excoriation there are excoriated lesions, and moreover there are scales all over the scalp. So this is a typical picture showing a child having atopic dermatitis. Then look at the popliteal fossa of this child. This shows lichenification or chronic atopic dermatitis. The skin is thick and shiny, and there are scales over the lesions. So this is an example of chronic phase of atopic dermatitis, when there is extensive thickening and scaling of the affected area. Then look at this picture. This is another example of atopic dermatitis. The extensor surfaces are involved and there is excoriation, and at some areas there may be secondary bacterial infection. So this picture also shows atopic dermatitis involving the extensor surfaces. Now, treatment of acute stage. Now, first of all, educate the family about the course of illness. Then they must avoid triggers. For example, in some children, this condition may be exaggerated by cow's milk, eggs, peanuts, fish, and then pollens, grass, the animal dander, wool, different soaps, different fragrances, and detergent. So, if a triggering agent is identified, then that must be avoided. Then wet dressings, they are helpful in curing the lesions. So as I have already told you people that there is extensive xerosis or dryness of skin. So in order to wet the area, in order to moisturize the area, we have to put wet dressings. Then application of medium potency steroids is helpful to cure the condition. Sometimes we have to give antibiotics, antiviral agents, antifungal agents to treat the superinfection. We can send different investigations, and the most important is the bacterial and herpes simplex virus cultures. Antihistamines may help to relieve the itching, which is very common in this condition. In the chronic phase, in addition to avoiding the irritants, we have to restore the water to the skin. So wet dressings play a vital role in providing relief to the patient. So no soap and harsh shampoos should be used. Avoid woolen or rough clothes. Bathing is minimized to every second or third day, and during bathing the irritant soaps should not be used. Daily lubrication of the skin with petroleum is important. Similarly, Cetaphil can be used, Cetaphil lotion can be used for the moisturizing purpose. Bathroom humidifiers is useful. In resistant cases, drugs like tacrolimus in the form of ointments or pimecrolimus can be used. Similarly, other drugs like cyclosporins can be used, as is the methotrexate, in very resistant cases. The complications of the illness are secondary infections, particularly the infection by Staph aureus, Streptococcus pyogenes, herpes simplex virus. The herpes simplex virus infection can lead to Kaposi verrucoliform eruption in these children. In addition to the bacterial infections, they can have fungal infections as well. The next common type of dermatitis is the contact dermatitis. Contact dermatitis is of two types: primary irritant dermatitis and allergic contact dermatitis. The primary irritant dermatitis results from prolonged or repetitive contact with physical, chemical, or mechanical irritants, including saliva, urine, feces, different types of fragrances, detergents, dyes, henna, etc. The primary irritant dermatitis develops within a few hours of contact and then reaches a peak in 24 hours and then disappears in 2 to 3 days. The examples are diaper dermatitis, dermatitis resulting from lip licking and thumb sucking. Diaper dermatitis is the most common form of primary irritant contact dermatitis, and this condition we will discuss in detail. On the other hand, the allergic eczematous dermatitis, it has delayed onset after the contact with the triggering agent, and the symptoms may begin after 18 hours and then ultimately they peak at 48 to 72 hours, and they may last longer than 2 to 3 weeks. For example, nickel dermatitis, shoe dermatitis, and topical neomycin can cause dermatitis at the area where it has been applied. Then various types of fragrances, various type of topical steroids, they can cause dermatitis. So it looks very odd that drugs like steroids, which are used in the treatment of dermatitis, can themselves cause dermatitis. Similarly, drugs like neomycin can cause dermatitis. Then we have diaper dermatitis. The prolonged contact of the skin with urine, which contains urea, and stools, which contain intestinal enzymes, can cause diaper dermatitis. So in case of diaper dermatitis, there will be erythema and scaling of the skin in the perianal area. History of prolonged contact with the urine and feces will be present, and this is frequently seen in good babies who sleep more and their pampers, they remain wet with urine and with feces for longer period of time. In 80% of the in 80% of the cases, this area may be colonized with Candida albicans. So after the initial erythema and scaling of the involved area, the second infection with Candida albicans can occur. Similarly, streptococcal perianal infection may cause cellulitis at the involved area. Ultimately, the area becomes beefy red, sharply marginated or demarcated from the adjacent normal skin. Now look at this picture. This picture shows that this child has diaper dermatitis. There is erythema and scaling in the area of diaper. So with the passage of time, this area becomes excoriated. There may be bleeding from the area, and there may be colonization of the area by the Candida albicans and by different bacteria like Staph aureus or Streptococcus. The treatment of this condition is that the mother should change the diaper of the baby frequently, wash the area with a wash cloth and warm water only after bowel movements. She should avoid rubber or plastic pads because they will not allow the area to dry. The plastic pads will keep the area moist or wet most of the time, and this will further aggravate the condition. Air drying is very useful. The babies should not be applied pampers or plastic pants during the daytime. Application of barrier creams such as zinc oxide cream with each diaper change is helpful to cure the condition and to prevent the condition. Sometimes when there is fungal infection suspected, we have to use antifungal creams like imidazole, and which should be applied twice a day. Lip licking dermatitis, you can see some children have of habit habit of the licking the lips, and they can develop a perioral dermatitis. This is called lip licking dermatitis, and of course this requires counseling of the child and maybe the application of mild steroids which can cure the condition. The next common type of dermatitis is the seborrheic dermatitis. So this is a erythematous scaly dermatitis. And the most important thing to be remembered is that it involves the areas which are rich in sebaceous glands like face, scalp, perineum. There is probably overproduction of sebum, and this condition is seen during the newborn period and then at puberty. So there may be effect of hormonal changes that causes seborrheic dermatitis. Malassezia furfur is a fungus that is said to be implicated in the pathogenesis of seborrheic dermatitis. The clinical features of this condition are that it may begin in the first month of life and resolve by 1 year of age. There will be scaling and crusting of the scalp. Sometimes it is so extensive over the scalp that it covers almost all the scalp, and this is known as cradle cap. The scales are greasy and the area looks erythematous. Usually it is a non-pruritic dermatitis, while atopic dermatitis, which we have already discussed, is pruritic. So in seborrheic dermatitis, the face, the neck, the retroauricular area, axilla, umbilicus and diaper area are involved. It may spread to involve the entire body. Now look at this child who is having seborrheic dermatitis. There are greasy scales over the face and the body. The face and the rest of the body is also involved. So this condition can involve the scalp, face, but at the same time it may become so extensive that it may involve the entire body. The treatment of seborrheic dermatitis is that you have to apply the low potency steroids to the affected area. Now the fourth and the common condition that affects the children is Petraeus alba. We usually see children who have white spots on their face, and the parents think that this condition is probably due to the deficiency of calcium in the body. So they are not correct. This condition is not due to calcium deficiency, but it is a kind of mild dermatitis. The exact cause is not known. So the child will have white scaly macules which have indistinct borders. Cheeks and extensor surfaces of the extremities are affected. Sunbath or sun tanning can exaggerate the lesion. Histological examination reveals mild dermatitis. It must be differentiated from a fungal infection which is known as tinea versicolor. Now if you look at this picture, this child has a white macular lesion with indistinct borders, and there may be small scales over the lesion. Sometimes the children may have white macules with indistinct borders over the extensor surfaces of the body and the rest of the face as well. So this is known as Petraeus alba, a fairly common condition, and it is treated with low potency topical steroids, and it has a very good prognosis. Regarding the prognosis of dermatitis, particularly the atopic dermatitis, patients or the parents should be reassured that as the age advances, the lesion tend to heal and the child will become normal. However, they must avoid irritants. The exposure to irritants can cause itching even in the later part of the life. Thank you very much.